A very good evening, everyone. A warm welcome to today's session on pre-implantation genetic testing part 2. This is a highly relevant and evolving area in reproductive medicine, and we are privileged to have with us an accomplished expert to guide us through it. It is my pleasure to introduce Dr. Ankita Srivastava, MCH resident in reproductive medicine and surgery at Amrita Institute of Medical Science, Kochi. Dr. Srivastava is a distinguished gynecologist and obstetrician with over 15 years of experience specializing in reproductive medicine and microvascular surgery. Her dedication extends beyond clinical practice. She has been an active researcher, educator, and mentor. She has received multiple honors, including the prestigious SAFOG Young Gynecologist Award and Sri Sabratnam Arul Kumaran Award for Best Paper. Dr. Srivastava has also contributed as a web editor of AOGD and continues to mentor at Zoe Nutrition, reflecting her passion for advancing knowledge and empowering patients as well as peers. We are honored to have her with us today to share her insights on this important topic. Without further ado, let's welcome Dr. Ankita Srivastava. Welcome, Doctor.
Thank you so much for the kind introduction. So, as you have spoken about, this is the second part of pre-implantation genetic testing. So, we are going to get right into it. So, the last time we had left it at the biopsy. Okay, so now we are coming to the types of blastocyst biopsy. Is my slide visible to everybody?
Yes.
All right. So we're going to talk about the different types of blastocyst biopsy and how it has evolved over the years. What are the advantages? What are the disadvantages of each? So as you can see in this representation, there are different types of biopsies that have been evolving. One was day 3 hatching when we do the laser method and then we leave it. So we leave it to culture till day 5 or day 7 and then it will hatch on its own. Then there is modular hatching based method, same day hatching based method wherein we conduct the the laser beam is directed and a hole is made and the same day it is hatched. Simultaneous zona pellucida opening and the trophoectoderm cell retrieval, which is a more complex procedure. So as you can see in the first two methods, we are waiting for days. After day 3 hatching based method, as well as the morula hatching based method, we're conducting the laser hole and then we're waiting for it to hatch for about a few days. Herein, wherein there is a same day hatching based method, we're only waiting for a few hours. And the last, the more complex method, we are conducting the opening as well as the trophoectoderm cell retrieval at the same time. So the approach entailing sequential hatching and biopsy results in a significant higher survival rate after thawing, implantation, clinical pregnancy, and the live birth weight if it is compared to the cleavage stage hatching approach. So as we go from cleavage stage to the sequential hatching and biopsy, the sequential hatching and biopsy has more advantages over the cleavage stage embryo biopsy. But does it have more benefit than the same day? No. So here we see the evolution. From 2005 up until 2016, what has happened, the evolution is that in the first go, the zona pellucida opening was conducted on day 3. Then it was incubated until herniation, until they start hatching. Biopsy of the hatching cells was done and it came with a risk of even the intracellular mass being herniated along with the trophoectoderm cells. So that was the risk it carried. When in 2014, it was changed to zona pellucida opening on day 5 and then direct intrazonal aspiration of cells and biopsy, or you leave it for spontaneous herniation and then you take the biopsy of the hatching cells. In 2016, what happened was zona pellucida opening was on early day 5. You incubate until herniation and then you do the biopsy of hatched cells or hatching cells. So here you see over the years, when we see that the zona pellucida opening has progressed from day 3 to day 5, the biopsy timing was earlier at blastocyst stage, which was from day 3. You conduct the zona pellucida opening on day 3 when it was done in 2005. That and then you leave it to culture till blastocyst stage day 5, day 6, day 7. Now, the limitation was that it can have potential intracellular mass herniation, and you are having it to expose to suboptimal conditions for longer, double exposure to suboptimal conditions. That is a disadvantage. But definitely the advantage was that there is easy zona pellucida opening, because when you're doing the zona pellucida opening at day 3, that means that there are lesser number of blastomeres, and the space between them is large enough so you can easily conduct um, the biopsy can be easily conducted. However, on day 5, when it was progressed to day 5, what we saw was that biopsy timing was immediate on day 5 when it was done in 2014. It may be more technically challenging for less experienced operators because cells are kind of stuck together. But the advantage is that it avoids the double exposure, and the disadvantage of intracellular mass being herniated is not there in this. Again, in 2016, this was improved further. Improvisation was done with the same technique by Capelbro. There was short incubation at day 5. Double exposure to suboptimal conditions was a limitation, but it did avoid the intracellular mass herniation. Now, when we go on to the main advantages of the blastocyst stage biopsy over the cleavage stage, what we found that embryos that underwent the trophectoderm biopsy at the blastocyst stage had comparable implantation rates to the non-biopsy sibling embryos, unlike the ones that were biopsied at the cleavage stage. And the main advantage of this blastocyst biopsy was that the trophectoderm basically is a non-embryonic tissue, so it avoids any interference with cells which are already committed to the inner cell mass differentiation. The biopsy is performed after embryonic genome activation, because at cleavage stage, the embryonic genome has not been activated yet. At cleavage stage, you do not know which cells are going in to form the trophectoderms and which cells are going to form the inner cell mass. But here, you already know. In the blastocyst stage, you know that these are my trophectoderm cells. I will not touch the inner cell mass. So the biopsy is performed after the embryonic gene activation, enhancing the embryo's reproductive potential compared to an earlier developmental stage. And a smaller proportion of embryonic mass will need to be removed, about 5 to 10 cells of the blastocyst. Wherein if you do the cleavage stage biopsy, you need cells, and this will represent a larger percentage of the embryo itself at that point. Wherein if you remove 5 to 10 cells out of the blastocyst, it's not a large percentage of the entire embryo. So now we see what are the differences in the cleavage stage biopsy and the blastocyst biopsy. In the cleavage stage biopsy, there are more embryos to analyze, because as and when it progresses to the blastocyst, only few embryos are left behind. Only the viable embryos will be left behind to analyze. Now, in the cleavage stage embryos, the embryos are more likely to have damage caused by the biopsy, whereas the blastocyst biopsy is less prone to damage, is more stronger at that point. Okay, cleavage stage biopsy has less material for genetic analysis. No diagnosis results may occur if up to 10% of cells are biopsied. In up to 10 cells, 10% of the cells biopsied, we may not even get a diagnosis. Whereas the blastocyst biopsy has more genetic material and we can have a better analysis. Then mosaicism is definitely more common in the cleavage stage biopsy, whereas only about 3 to 24% mosaicism is seen in the blastocyst stage. But what are the traditional PGTA? What are the challenges with it? Biopsy of multiple trophectoderm cells could potentially damage the embryos, and recent evidence does suggest that you have only a limited cell removal, about 3 to 10 cells, and this will not reduce your implantation rates. What are the advantages of the non-invasive approaches to the PGTA. It will not have any damage to the embryos. It will have potentially lower costs. It is not a replacement for traditional PGTA, but the non-invasive PGTA provides an alternative and safer method. So what are the non-invasive methods? We understood that with the PGTA, with the invasion, what are the disadvantages and advantages of the cleavage stage, of the blastocyst stage, embryo biopsy. Now, what are the non-invasive methods and how are they safer? And what are the future prospects in research for them? So basically, we have to collect the embryo-derived DNA. So we can collect it from the blastocele fluid aspiration, known as blastocentesis, or the spent culture media. You have cultured the embryos, the spent culture is there. There you can extract the DNA of the embryos. So now let's talk about blastocentesis, or the blastocele fluid aspiration. Blastoccentesis basically means that there is aspiration of the blastocele fluid from the embryonic activity. Now you go through the trophoectoderm cells. You go through the trophoectoderm wall, wherein these are destined to form the placenta, and you use the ICSI needle. You must avoid aspiration of cellular material to prevent non-representative fragments. Now, this sample which is collected, this is enriched of fragmented DNA of the embryonic origin. Now, there can be DNA quality challenges because there could be low quantity as well as poor quality of the blastocele derived DNA, which is there in the blastocyst fluid. Now, DNA amplification can be there, which the efficiency can range from anything between 34% to as high as 87%. And there could be difference in the concordance rates, differ between blastocentesis and conventional biopsy procedures as well. So it may not be thoroughly representative. We still need further research for it. So the concordance rate may differ. Now, what about the ease versus trophoectoderm biopsy? Yes, definitely there is easier application, but it requires further validation, it requires further development. And for the better survival after vitrification, you have to collapse the blastocele cavity. Now, what about spent culture media? The embryonic DNA in the spent culture media, this is a non-invasive method, and embryonic DNA is detected as early as day 2 or day 3 of the development. Now, what you will do is you will not manipulate the embryo, you will just take the culture media, whatever DNA is there, you test from that. So you're not touching the embryo at all. Now, this has to involve careful denudation of the cumulus cells, extensive washing and changing media before the sampling. This is less invasive even than blastocentesis. Now, what about the DNA quality in the spent cell culture? Here, DNA quality and integrity is superior to the DNA quality and integrity is superior in spent culture media when you compare it to blastocele fluid, because blastocele fluid contains the fragmented DNA. Now, the parameters inferior to trophoectoderm biopsy specimens, obviously the invasive trophoectoderm biopsy is more reliable, more accurate. So the parameters are a little inferior to the trophoectoderm biopsy, but superior to the blastocele fluid. And the cell-free DNA availability depends on the embryo culture length, how long you have cultured, and whether there is external DNA contamination. So how can you optimize the spent culture medium collection for improved efficacy? What you can do is you change the media on day 4, followed by the spent culture media collection on either day 5, 6, or 7. This will enhance your DNA yield. This method also lowers the chances of including the maternal DNA from the cumulus cells. So DNA contamination will be prevented because you're removing off the cumulus cells from the maternal DNA, or freely circulating in the culture media. If they are from the maternal DNA, from the cumulus cells, if they were freely circulating in the culture media, you're removing that. Okay, so you have a pure sample. Now, despite DNA amplification improvements, more than 95% improvement, diagnostic efficacy is only about 80%. So when you compare it to the trophoectoderm biopsy, it is definitely not satisfactory. It needs more research, more validation, but it could be a very good non-invasive method wherein you're not touching the embryo at all. Whole genome methylation sequencing, basically, it's used for the non-invasive PGTA to detect differentially methylated regions. Now, These regions could be characteristic of the blastocyst, the cumulus cells, and the oocyte or polar body DNA. So differential methylation region they are being detected. This allows for the identification of the origin of the cell-free DNA, providing additional information beyond just the copy number analysis. Now, what are the challenges we face in the non-invasive PGTA? You have to optimize the whole genome amplification from fragmented cell-free DNA. The copy number analysis alone in the non-invasive PGTA does not allow where the cell-free DNA is coming from. It does not tell us about the origin of the cell-free DNA. This means that while the aneuploidies can be identified, it may still be challenging to determine whether the DNA comes from the blastocyst, it comes from the cumulus cells, it comes from the oocyte or the polar body. So we do not know the origin of the cell-free DNA. And the detection of DNA from the second polar body is important in non-invasive PGTA because it can persist to the blastocyst stage, potentially leading to false results at both the chromosomal as well as single gene levels. This underscores the need for comprehensive protocols that consider the potential impact of maternal contamination on non-invasive PGTA results. Now, why might the protocols that include the analysis of genome-wide SNP markers be necessary in the non-invasive PGTA? Why? Because we want to avoid false negative results caused by maternal contamination. Because these markers will help to differentiate between maternal and embryonic DNA and it will enhance the accuracy as well as reliability of the non-invasive PGTA. That's why these markers are so important. Now, there was a recent multi-centric prospective study regarding the concordance between cell-free DNA as well as trophoectoderm biopsies in human blastocysts. And we found that the concordance was about 78%. False positive rate was as high as 12%. False negative rate was also 8%. We found that maternal contamination was about 12.5% and the failure rate was about 12%. So we do need further processing of biopsy sample, spreading on slide for fish, tubing for other analysis platforms. We need more progress and more research. Genetic analysis platforms could be the fish, PCR, microarray, the single nucleotide polymorphism, the comparative genomic hybridization, the next generation sequencing, as well as the massive parallel sequencing. All these are the genetic platforms for PGT. Now, if I just tell you what are the PGTA techniques used and what have been the key developments, what happened 15 years ago and what is happening now, what are the advancements over the last 15 years, let me just tell you briefly about. So basically, earlier, about 15 years back, there was only polar body or cleavage stage biopsy. Fish was done with about 7 to 9 probes. So what was there? The limited number of chromosome-specific probes were there. There were RCTs which failed to show benefit. And there was a Netherlands trial which showed reduced live births when you conduct the polar body or cleavage stage biopsy. But over the last 15 years, we have involved whole genome amplification, copy number analysis for all 24 chromosomes has been done. Now the progression from array CGH to NGS-based tests, NGS-based targeted sequencing of the SNP markers for improved accuracy, improved culture to blastocyst stage, cryopreservation by vitrification. All that has come into play. And the effective approaches of blastocyst culture, trophoectoderm biopsy, PGTA, vitrification and transfer in the later unstimulated cycles has been coming up. Exceptionally high implantation rates and live birth rates per transfer has been seen. Reports demonstrate the effectiveness of this approach and non-selection study did confirm high success rates with PGTA now. And what are the benefits when you combine the time-lapse analysis, which is a non-invasive, basically you're seeing the morphokinetics of the development of the embryo, the vitrification process, and the pre-implantation genetic testing for aneuploidy A at the blastocyst stage. If you combine all of that, you get a higher live birth rate. Higher implantation rates are there because there are better chances of embryos successfully attaching to the uterus. High clinical pregnancy rates are there, low miscarriages are there. You can do a single euploid vitrified warm transfer. So you're also giving healthy embryos, and you're also negating the multiple pregnancies. Cryostorage of the euploid blastocysts only. Only cryopreserve the euploid blastocysts, and they will also withstand the freezing procedure better. Only genetically normal ones. Reduced risk of chromosomally abnormal outcomes. You'll have less pregnancies and births with genetic issues. Improved clinical management can be there, overall patient care, time to pregnancy can be reduced, treatment can be more satisfactory for the patient, and this also gives us elevated embryology standards, high quality lab practices, improved decision making between the patient as well as the doctor. Now, briefly, let's talk about fish. The fluorescent in situ hybridization basically uses fluorescently tagged DNA probes that bind to their complementary sequence, and this can be visualized under a fluorescent microscope. So you have the probes and they will go and bind to their complementary sequence. You just need a fluorescent microscope for it. So here you can see the tagged probes have gone and combined to their counterpart, and this is positive for trisomy 21. So this patient might be having a trisomy 21, and this probe of the trisomy 21 alteration has gone and attached to it. So that's how you know that this patient has trisomy 20. Genetic material. Now, salient features are this has rapid turnaround time, does not require amplification. But the limitations are there are only limited number of chromosomes that can be examined. You have to have the probes for it, the labeled probes for it. And it is unable to evaluate all 23 chromosomes. Only 5 spectrally distinct fluorochromes are available in label the probes to label the probes. The largest number of chromosomes that have been reliably done in analyzed in a single study was about 15. Okay, and this was performed over 3 rounds. Repeated rounds of fish performed in the same fixed cells are associated with declining accuracy and obviously disintegration of the nucleus. There could be hybridization errors, errors in subjective interpretation of fluorescent signals, or they could be introduced while you perform the procedure itself, like errors during the fixation of the cells, during the attachment of the probes, multiple washings. They can also disintegrate the nucleus and give false results, and of course, introduction of artifacts. Now, what about using of fish for the PGTM, the monogenic disorders? May only be used for sex determination of embryos in sex-linked monogenic disorders. Because we have only 5 to 15 times, I mean, we have 5 probes for it, and up to 15 have been diagnosed in a study. It cannot detect point mutations. Now, what about PCR? Fish we have spoken about. What about PCR? PCR amplifies small quantities of DNA to a level at which they can be visualized and subjected to further genetic analysis. So you have a small amount of DNA material, you amplify it, and then you can analyze it. That is the whole principle, right? The PCR thermocycler is programmed to perform successive cycles constituting of denaturation. You denature the DNA strands, annealing, and extension. Now, the denaturation at temperatures of about 90 degrees Celsius takes place. Now, the double-stranded template DNA melts into 2 separate single strands, as you know. As you can see in the diagram also, you have the DNA, original DNA, which is to be replicated. Now, you take it to a temperature of about 94 to 96 degrees, above 90 degrees it should be. So, you separate these single strands. Now there is the process of annealing. Now the primers attach to their region of homology. And then this, you make it grow, extend. New nucleotides are being added in succession to recreate a double-stranded DNA molecule by the enzymatic action of the thermostable Taq polymerase. Now you're increasing the DNA material, you're amplifying the DNA material for detection. The resulting new strands serve as templates for the subsequent cycles. Now you conduct another cycle. You have the denaturation, annealing, and extension again. After 30 to 40 such cycles, the initial minute quantity of DNA is amplified to the extent that it can actually be visualized by methods such as radioactive labeling, ethidium bromide, or silver staining. Now, there is amplification of the gene locus of interest for PGTM because there's a monogenic disorder. You know the gene, and now this is the gene of interest, and you're trying to amplify it. Or there is a qPCR for PGTA, which we will discuss. Now, drawbacks of PCR for PGTM. For monogenic disorders, what is the drawback? You have a genetic locus, gene locus that you want to study, amplify and study. Now, there could be decline in amplification efficiency. There could be allele dropout. Amplification failure can be there and contamination can be there. And how does each of these happen? Let us discuss in detail. What about decline in amplification efficiency? The number of cycles that may be performed in standard PCR is limited by a gradual decline in amplification efficiency with each subsequent cycle due to the decrease in the activity of the Taq polymerase over time. In a single cell PGT analysis, the quantity of amplified DNA may be insufficient for a complete molecular analysis, and this fraying of amplicon edges by exonuclease activity of Taq polymerase. So there is fraying of amplicon edges. So all these, the decrease of quality and the decrease in the activity of the Taq polymerase, the fraying, all this reduces the quantity as well as the quality of the genetic material being studied. So what is the solution for it? The solution is nested PCR. There are two sequential rounds of PCR which are being used. The primary generates DNA fragments encompassing the mutation site, but they are insufficient in number to be visualized. Now, the PCR products from the first reaction are transferred to a new PCR tube and are amplified to detectable levels using a different set of primers situated internally to the first. So this strategy enhances the specificity as well as sensitivity of PCR. So you see the nested PCR, the non-specific application of DNA is there. First, in the first round of amplification, use the outer primers. The target DNA is taken and amplified. Now, in the second round of amplification, we use inner primers. Now, the first amplicon is transferred to another separate tube, and there is specific applications of the target DNA. In simpler terms, the nested PCR overcomes the limitations by refining the amplification process, especially in situations with minimal DNA templates. It may fail in about 10% of blastomeres. The PCR process may fail in about 10% of blastomeres due to the factors like biopsy technique, which could be improper, or there could be insufficient or poor quality DNA samples which may fail to yield the amplified DNA material during PCR, or cell conditions itself. The cells may be damaged, they may be stressed or abnormal, they may have degraded DNA or impaired enzymatic activity, making them less suitable for PCR amplification. Now, what are the allele dropouts? We studied, right? Like when you see the disadvantages, drawbacks, the second one was the first is decline in amplification efficiency, which we have studied in detail. Now we come to the allele dropout. So with allele dropout, we are talking about the phenomenon where only one of the two alleles present in a cell is amplified to a detectable level. So there may be two alleles which need to be amplified, but only one of them is amplified to a detectable level. So significant implication in PGD, especially for dominant disorders, will lead to misdiagnosis because one of the allele is not being detected at all. In general, it generally affects about 5 to 30% of single cell amplifications. And allele dropout is higher in blastomeres, possibly because of their higher haploidy rate. So you can see in this diagram, when you were doing PCR, what you were doing was you were separating the strands, you are actually amplifying the DNA and taking them as a base and making more DNA copies. Now here, when you see in the second diagram, there's DNA. It is the one allele is not being amplified at all, and it is not being detected at all. So when you see the red is not being detected in the PCR amplification, and you see both blues. So this can be quite dangerous, especially when we are checking for the autosomal dominant disorders. And what are the causes of the allele dropout? There could be inaccessibility of the DNA template due to imperfect denaturating temperature. Incomplete cell, either the temperature was not proper, or there is incomplete cell lysis and DNA degradation prior to PCR. So proper cell lysis is very, very important to release intact DNA for subsequent PCR amplification. DNA deterioration or damage such as strand breaks caused by endogenous nucleases can also be one of the causes. And degenerated and apoptotic cells show increased allele dropout, probably due to partial degradation of the DNA strands. It has been suggested that this is higher in blastomeres than in the other cell types. And what are the implications? So when you see the autosomal recessive conditions, what you see is that there's an affected embryo, there's a carrier embryo. So you may transfer the carrier embryos, but you don't have to transfer the affected embryo. So for autosomal recessive conditions, when both partners are carrying the same mutation, like this in the first diagram, the allele dropout should not result in the transfer of an affected embryo. However, the number of embryos available for transfer will decrease as the allele dropout rate increases, potentially reducing the likelihood of pregnancy. And in this case, carrier embryos will also be disregarded and they will be disposed of. In autosomal dominant conditions also, what will you see? Here, none of the embryos are being transferred, whether there is affected embryo or the ones that are carrying just one allele is carrying, because they're affected. In all these conditions, they're affected, whether one gene is carrying the mutation or both. For compound heterozygous or autosomal dominant conditions, the consequences can be catastrophic as misdiagnosis and subsequent transfer of affected embryos can occur. So how do you avoid allele dropout? Advanced PGT protocols using techniques like multiplex PCR, QF-PCR quantiferin, and the RT-PCR. Inclusion of flanking polymorphic markers for accuracy, use of 2 cells from each embryo for genetic analysis to be sure, and adoption of karyotype mapping, which we'll discuss, to overcome the allele dropout and enhance diagnosis reliability. Now, what is multiplex PCR? Multiplex PCR refers to the simultaneous amplification of more than one fragment in the same PCR reaction using more than one pair of unrelated primers. The successful multiplex PCR reactions enable simultaneous assessment of numerous loci. And this can check for things like specific genetic problems, abnormal numbers of chromosomes and aneuploidies, and even include markers to help reduction in the risk of contamination and allele dropout. So what do you do in multiplex PCR? There's a mutation site. Okay, so what you do is there is amplification of both the loci. The two loci, the red and green, you can see, there's amplification of both the loci. So you're avoiding the allele dropout. You're conducting at simultaneous amplification of more than one fragment in the same PCR. And you use more than one pair of unrelated primers. So what will happen is there is simultaneous assessment of numerous loci, as you can see, and this will avoid the allele dropout. Now, what about amplification failure? The main reasons for amplification failure include biopsy technique could be wrong, there could be premature cell lysis, lysis protocol which you have used is a problem, and PCR conditions. Now, contamination in PGD. There could be paternal genome contamination which may arise from the spermatozoa embedded in the zona pellucida after IVF technique. Now, the risk during sampling of blastomere, the second polar body, or trophoectodermal cells in the embryo biopsies by when you employ ICSI, the PGD units can mitigate the risk of contamination and improve the rate of success. Now, what about maternal cumulus cell contamination? It originates, as we have spoken about, from the cumulus cells which were adherent to the oocytes, which is this risk can be reduced when you mechanically or enzymatically strip off the cumulus cells from the zona pellucida. And when you're talking about the lab technicians, the lab conditions, that can also contribute to the external contamination. Or you may have PCR products from the previous experiments, which may be contaminating this. Risk is influenced by the number of PCR cycles which are needed for sufficient DNA amplification also. Now, what about PCR for the quantitative polymerase chain reaction or real-time PCR, which will help in PGTA and improve the success and measures the relative quantities of 4 specific loci per chromosome in just about 4 hours without whole genome amplification. Now, this can easily identify aneuploidy of all 23 pairs of chromosomes in a rapid fashion within 4 to 12 hours, depending on the number of samples which are analyzed. This is much more rapid, inexpensive method than array-based methods. And this is also giving us faster results and more accurate ones. Now, the quantitative PCR or the real-time PCR basically is the method wherein the very low number of regions are evaluated. So, but what is the advantages of being more accurate as well as faster? But what about the limitation? The number of samples that can be processed concurrently on one machine is quite low. So there is difficulty in evaluating multiple cycles and multiple samples simultaneously. Now it tests a relatively small number of loci along each chromosome and is laborious. Since it is very labor intensive, automation is quite recommended. It cannot detect the structural chromosomal aberration. Since it does not generate a genotype, it cannot identify uniparental disomy. And amplification failure can be there in approximately 10% of isolated blastomeres. So let's go on to the microarrays now. There are two main types of microarrays available for genetic testing. They are the single nucleotide polymorphism and comparative genomic hybridization arrays. The microarrays were developed with the ability to test for all 23 pairs of chromosomes for aneuploidy, simultaneously testing for structural chromosomal aberrations. So for both microarray platforms, the trophoectoderm cells must be lysed and amplified by some type of DNA amplification protocol that provides the whole genome coverage. Now, when we come to the more advanced methods, just 1 minute. Methods which are designed to achieve non-specific amplification of the entire genome. Now, there are several techniques. There could be primer extension pre-amplification, degenerate oligonucleotide primed PCR, and multiple displacement amplification. This is just to name them. We will be talking about them in detail. CGH array, basically here what we do is patient and control DNA are labeled with fluorescent dyes and hybridized to a DNA microarray. Both DNAs compete to attach or hybridize on the microarray. So you can see that there is co-hybridization on the microarray. The microarray scanner measures the fluorescence signals. So you can see you scan them, you have the signal detection, and a software analyzes the data and generates a plot. So you have a reference DNA and you have a test DNA. You conduct DNA labeling. Co-hybridization is done on the DNA microarray. The signals are picked up and measure the fluorescent signals on it, and then the plot is generated by a software. After amplification, the sample is labeled with fluorescent probes and hybridized to a DNA microarray. Now you hybridize it to a DNA microarray. The color adopted by each spot after hybridization allows for identifying chromosomal loss or gain. Okay, so this is the comparative genomic hybridization arrays. You can see in the diagram, the signals are being picked up. So as you can see in the first figure, here the figure shows examples of several different samples evaluated by CGH array for the pre-implantation genetic screening. The figure on the left is diploid with a relatively equal ratio of green and red fluorescence in all 23 chromosomes, 23 pairs of chromosomes. But the figure on the top right shows monosomy for chromosome 2. You can see on the figure on the right top, monosomy for chromosome 2 with a clear downward deviation of the plotted line, indicating a relative lack of green as compared to red signal intensity. And when you see the bottom right one, you see the tries, you can see the green going up, the tries on the chromosome 13 level. So the right figure shows, or the right bottom figure shows trisomy for chromosome 13, an extra chromosome, with a clear upward deviation of the plotted line, indicating a relative increase of green as compared to the red signal intensity. So that is how the CGH arrays are being read. So there will be the advantage is that a complete chromosomal analysis of all the 23 pairs of chromosomes is being done. Now it detects the copy number changes at a level of about 5 to 10 kbp of DNA sequences, identifies microdeletions and duplications, and detects structural variations at resolution of 200 base pairs 24-hour process. So it is shorter, it is faster also. And the limitations are it's quite expensive. Levels of mosaicism of 20% or less cannot be detected. And the balanced reciprocal translocations, the inversions, whenever there is balance, there is not addition or deletion. If there's balanced translocations, inversions, Robertsonian translocations, reciprocal insertions, uniparental disomy, and triploidy, they cannot be detected because there are no additions or subtraction of the genes. It's all balanced. So the signal cannot pick it up. Okay, so now we see the PGTA techniques and how it has been studied by various groups. So Yang et al., he had studied women under 35 with tubal or male factor infertility by the CGHS method plus morphology versus morphology alone. And here they found that the rate was significantly higher in the PGTA group compared to the morphology alone group, as well as the ongoing pregnancy showed a significantly higher rate when PGTA was done as opposed to the morphology group alone. When Scott et al. Did this on women in the biopsy group underwent PGTA, followed by the fresh transfer of up to 2 euploid blastocysts, and the control group received the transfer of 2 untested blastocysts. Real-time quantitative PCR was done, and it was compared to the traditional morphology. The implantation rate per embryo transferred in the PGTA group was notably higher, and when they demonstrated a significantly higher rate of implantation, sustained implantation rate, clinical pregnancy rate was also improved when PGTA was done as opposed to the morphology alone group. And even the live birth rate was improved in those patients. Rubio et al. Conducted in an older population wherein what he did was cleavage stage blastomeres were checked with the CGH method. They were fresh transfers of euploid blastocysts, and there was an increased delivery rate, shorter time to pregnancy rate in the PGTA group, and transfers which were necessary. That was fewer. That means time to pregnancy was reduced. So now the field shifted to trophoectoderm biopsy post Scott et al. Trial on blastomere biopsy effects. So this Rubio trial was done on an older population on the cleavage stage blastomere. But when you go on to the STAR trial, in contrast to the Rubio trial, the STAR trial designed to compare outcomes using PGTA via next generation sequencing found no significant improvement in the clinical pregnancy or miscarriage rate. The trial included women between 25 to 40 with at least 2 blastocysts should be available for biopsy or transfer. And the overall ongoing pregnancy rate per transfer at more than 20 weeks gestation was similar between groups with no improvement in the PGTA group, according to the STAR trial. So let me talk about STAR trial briefly. It is a single embryo transfer of euploid embryo. The objective was to compare the outcomes of embryo selection using the PGTA via the next generation sequencing. The women were about 25 to 40 age and they at least had 2 blastocysts available for transfer. It was a large RCT conducted in the United States, United Kingdom, and Australia. And the selection of embryos for transfer was using PGTA via NGS, the next generation sequencing. There was no significant improvement in the clinical pregnancy rates, the miscarriage rates, the overall ongoing pregnancy rates. And it was similar in both the groups with no improvement in the PGTA group. So when we compare the Rubio trial versus the STAR trial, what we found in the PGTA outcomes, when we see the Rubio trial, they evaluated PGTA in older population, whereas STAR trial compared the selected embryos for transfer in the NGS group. Age group 38 to 41 in the Rubio trial, and STAR trial included age group of 25 to 40. Cleavage stage biopsy was used in the Rubio trial using the CGH method, and in STAR trial, PGTA via NGS method was used. In Rubio trial, fresh transfer was done of the euploid blastocyst, and in STAR trial, single embryo transfer of the euploid embryos was done. So in Rubio trial, PGTA group had an increased delivery rate per transfer. But in STAR trial, there was no improvement in the PGTA group of the live birth rate or the ongoing pregnancy rate, the clinical pregnancy rate, all that did not change. Time to pregnancy was faster in the Rubio trial, whereas it was not specified in the STAR trial. Number of necessary transfers were fewer in PGTA group in the Rubio trial. It was not specified in the STAR trial. Now, when we speak about the evolution of biopsy methodology, earlier the Rubio trial included the cleavage stage biopsy stage transfer, but shifted to almost exclusive trophoectoderm biopsy at the expanded blastocyst stage when he found that there was detrimental effects of the blastomere biopsy. Here in the STAR trial, we almost exclusively did the trophoectoderm biopsy. The mosaic embryos were not included in the Rubio trial. Whereas in the STAR trial, if there was intermediate copy number in the mosaic embryos, they were deemed aneuploid and not eligible for transfer. And subsequent studies suggested potential live births with mosaic embryos. It was not specified for this age range what was the impact in the ongoing pregnancy rate in the Rubio trial. Whereas in the STAR trial, they had significantly higher ongoing pregnancy rate in the PGTA group in the specific 35 to 40 years age group. So when we talk about 25 to 35 in the STAR trial, there was no benefit. But in the 35 to 40 group, there was a higher ongoing pregnancy rate in the STAR trial. Now, this is the largest RCT evaluating the impact of PGTA versus in the NGS group technology on ART outcomes, and was published in 2021. It was a multi-centric RCT evaluating the impact of PGTA via NGS technology, and they are the patients who are undergoing their first IVF cycle with 3 or more high-quality blastocysts. And they saw that the cumulative live birth following a maximum of 3 transfers between PGT and control groups, they were about 77.82% versus 81. So this says that the cumulative outcomes raise concerns about the impact of PGTA on overall success rate in the ART group. So this was the largest, published in 2021. Now the SNP microarray. These are the pairs of single nucleotide in the genomic DNA that are highly variable within a specific species. In the species, these single nucleotides in genomic DNA are highly variable, A, T, G, and C. Now, the microarrays provide a genotype, which is the AA or AB or BB for each sample analyzed, and compare these results to a human map reference gene. Okay, so the single nucleotide Polymorphism array basically takes the DNA. There is amplification, labeling of the DNA, hybridization of the DNA, and then you pick it up. Whether there is normal DNA, whether there is deletion, or there is duplication, that you will be able to pick up. So these arrays can identify the whole chromosome aneuploidies. This is the advantage. Whole chromosome aneuploidies can be detected and also identifies common structural chromosome aberrations throughout the genome. So structural chromosomal aberrations are being picked up. Unlike the CGH microarray, the SNP microarray do not use a known normal DNA sample, but they compare these results with a normal reference genome, which is the human HapMap. Now, the single gene disorders can be diagnosed at the same time as aneuploidy by karyomapping, and it can identify uniparental disomy also. So, the disadvantages of the CGH are being turned into advantages with the SNPs. They can identify the uniparental disomy, they can identify the single gene disorders, and they can compare the whole genome with a normal reference gene. But the demerits are there is inability of their algorithm to identify copy number when there is consanguinity. Limited ability to identify triploidy. It takes about 30 to 40 hours to complete the analysis, and it is much more expensive than the other alternative methods. Now, next generation sequencing. Here, after embryo biopsy, what we do is the amplification products are fragmented, producing millions of short pieces of DNA, which are then simultaneously sequenced in parallel and alignment with reference to the known sequence, which is the HapMap. So again, human genome of a known healthy human is being taken as the reference and human HapMap, and then they are comparing. So you can see here this being conducted. So there is a DNA target, which is in orange, okay? And here the entire genome is being sequenced. See, next generation sequencing, it will be able to simultaneously check for many chromosomal abnormalities, known defects, as well as mitochondrial mutations, okay? And here you can see that the chromosomal mosaicism in the blastocyst biopsy samples are detected with greater certainty, but cost is also the cost of CCS using NGS is significantly lesser. Now, there are advantages over other pre-implantation genetic methods. The cost is lesser. Obviously, there is a higher dynamic range signal to noise ratio compared to other methods. This sensitivity allows the detection of subtle anomalies, like the chromosomal mosaicism in blastocyst biopsy samples with greater certainty. And now recent data is showing us that embryos associated with mosaic trophoectoderm biopsy may have diminished implantation potential. However, these embryos could still be considered for the transfer in the absence of euploid embryos following appropriate patient counseling. Drawbacks of next generation sequencing are its relatively complex workflow and the necessity to cryopreserve the embryos post-biopsy is there. Freezing embryos isn't because NGS takes a longer time, but rather because the sequencing equipment works more efficiently when processes a large number of samples at once. This is done to keep the cost of the genetic screening lower. This efficient processing, however, often means that samples from several patients need to be collected over a few days before running the sequencing equipment, and that's why freezing embryos becomes necessary. Okay, so non-selection studies indicate transferring PGTA tested embryos without prior knowledge of the genetic test results. These studies allow for a retrospective analysis of the outcomes of the aneuploid transfers, providing insights into the potential impact of false positive results. So these studies help evaluate the validity of PGTA by assessing the actual outcomes of embryos that were initially classified as aneuploid. So here you can see SNP arrays, the technology used. Number of embryos was 255. Aneuploidy was 99 embryos. And live births you got 4. So negative predictive value was 96%. And when you saw the next generation sequencing, the negative predicting value was about 100%, because out of 102 aneuploid embryos that were detected, none of them showed live births. So earlier method was CGH. Let's compare it to the NGS based copy number profiling. So when you compare, they have the read depth of CGH is lower, whereas it has more information with the NGS based copy number profiling. We have more information. There's a non-linear relationship with copy numbers in CGH, but there's a linear relationship making it more comprehensive, accurate, and precise in the NGS method. In the CGH method, there is limited ability to identify detailed changes in chromosome copy, whereas in the NGS, it can identify both whole and segmental chromosomal anomalies, aneuploidies. So it is more detailed. In the CGH, it requires more genetic material. It may be performed at various stages, but in NGS, it is typically performed at the blastocyst with multiple trophoectoderm cell samples. CGH has lower resolution. It may miss the finer genetic variations, whereas NGS has increased resolution and wider. It can have better clarity, can have more detailed genetic analysis. CGH typically detects major changes like trisomies or monosomies, but the NGS can detect a wide range of changes, including low or intermediate copy number variations. CGH may struggle with interpreting the mosaic changes, but NGS has a better interpretation of mosaic changes due to increased resolution. And CGH is less prone to technical artifacts, but NGS may encounter low copy number. So when we compare all the methods, what are you detecting from each method? So whatever we have studied so far, this is a basic summary of it. Quantitative PCR, NGS, ACGH, and SNP microarray. The structural aberrations are not picked up by the PCR, but CGH and the single nucleotide polymorphism microarray can pick it up. Single nucleotide mutations or point mutations can definitely be picked up by the SNP microarray and the CGH, not by PCR and the next generation sequencing. Mosaicism is best picked up by the next generation sequencing. And if the mosaicism is more than 20%, it can be tested. It can be picked up by the CGH to some extent as well. Triploidy, it can be picked up by the quantitative PCR, by the next generation sequencing, not by CGH and not properly by the SNP microarray. Uniparental disomy can be picked up by the next generation sequencing and the SNP microarray. The cost is lowest in the PCR and highest in SNP microarray. Before we finish and close, briefly about mosaicism. Mosaicism is the presence of a mixture of chromosomally different cell lines in an embryo. Two or more different abnormal cell lines can be aneuploid as well as normal, or an abnormal cell line can be there, wherein you have euploid and aneuploid together. The origin of mosaicism is related to mitotic errors happening after fertilization. Occasionally, mosaicism may derive from a meiotic non-disjunction event causing a trisomic conceptus followed by a post-zygotic event, which is a trisomy rescue. Now, basically in 2015, it was demonstrated that mosaic diploid or aneuploid embryos were suitable for implantation, giving birth to healthy babies also. In this study, about 18 diploid or aneuploid mosaic embryos were diagnosed by CGH and were transferred in women who did not have any euploid blastocyst for frozen embryo transfer. The implantation rate was about 44% in this study with a live birth rate of 33%. Every fetus was confirmed through chorionic villi to have a normal karyotype, and strict prenatal monitoring is required. Amniocentesis can be done or CVS can be done when you're transferring the mosaic embryos. Now, the impact of mosaicism transferring a mosaic embryo may result in either no pregnancy or you can have a biochemical pregnancy, or you can have a miscarriage, birth of a mosaic child with birth defects, mental retardation, or in about 30%, you may have a healthy live birth of chromosomally normal child. Proposed etiologies for this success include self-correction of the mosaicism or inaccuracy of the initial embryo biopsy. So why are these 30% having a healthy birth of a healthy child? Because either the initial embryo biopsy was inaccurate or there is a method of self-correction of the mosaicism by the embryo. Embryos with a low percentage of aneuploid cells may have a better chance of implanting. Cutoff for definition of mosaicism is about more than 20%. Less than 20% levels should be treated as normal or euploid. More than 80% as abnormal or aneuploid. And the remaining 20 to 80% are the euploid aneuploid mosaicism. Transfer of blastocysts with a normal euploid result should always be prioritized over those with mosaic aneuploid results. And how do you report? The new method of see this, as you can see, the first one is euploid. Second one, you can see the reds in between, that is showing mosaic, and aneuploids are the complete red ones. So the different level of mosaicism should be reported and used to avoid discarding of potentially viable embryos and prioritize transfer of euploid versus mosaic embryos. So you have to quote the percentage of the mosaicism. Below 20 will be euploid. As you can see in the diagram, below 20 is euploid. More than 80 is aneuploid. Between 20 to 80, depending on the percentage, will be decided whether it will be transferred or not. But you have to counsel the patient that we are transferring mosaic embryos, and you have to make sure that an invasive testing of CVS or amniocentesis has to be conducted. Now, prospective non-selection trials, the equivalent developmental potential between euploid and low to moderate level mosaic embryos was demonstrated. So you can see in the diagram, in the chart, sorry. So when you see the embryo type, when you see if there is uniformly euploid, low mosaic or moderate mosaic. If it is uniformly euploid, you see that the pregnancy rate is higher. When you see low mosaic, it may be similar, but moderate mosaic will not be, it will not give a good result. When considering the transfer of a blastocyst with mosaic aneuploidies, you have to transfer the blastocyst with mosaic aneuploidies for low risk chromosomes only after thorough and appropriate genetic counseling. Appropriate monitoring and prenatal diagnosis of any resulting pregnancy, preferably by amniocentesis at more than 14 weeks gestation, has to be done. Now, what are these low risk chromosomes? Mosaic embryo trisomies for chromosome 1, 3, 4, 5, 6, 8, 9, 10, 11, 12, 17, 19, 20, 22, XY. None of these chromosomes involve the adverse characteristics enumerated below. Now, embryos mosaic for trisomies that are associated with potential for uniparental disomy, like 14 and 15, they are of less priority. Embryos mosaic for trisomies that are associated with intrauterine growth restriction, like chromosome 2, 7, and 16, they are of lesser priority. And embryos mosaic for chromosomes, trisomies capable of live born viability, like 13, 18, 21, they are of lowest priority for obvious reasons. Now, what are the ACOG? What does ACOG recommend for PGT? See, the false positive and negatives are possible. A normal or negative pre-implantation genetic test result is not a guarantee of a newborn without genetic abnormalities. Traditional diagnostic testing or screening for aneuploidy should be offered to all patients who have had pre-implantation genetic testing, aneuploidy in concordance with recommendations for all pregnant patients. Confirmation of the PGT for the monosomic and the structural results with the CVS or amniocentesis should definitely be offered. So even when you have tested with PGT or SR, you have to confirm with CVS or amniocentesis. And the clinical utility of PGTM and PGT-SR is firmly established. However, the best use of PGTA remains to be determined. Now, ASRM has some important considerations about PGTA that must be addressed by further research, which includes the cost effectiveness, the role and effect of cryopreservation, the time to pregnancy, utility in specific subgroups such as recurrent loss, prior implantation failure, advanced maternal age, etc. And cumulative success rates over time has to be seen, and total reproductive potential per intervention has to be seen. The committee opinion in ASRM 2018 for elective single embryo transfer when PGTA is being done. The value of PGTA as a universal screening test for all IVF patients has to be determined. Some studies have demonstrated higher birth rates after aneuploidy testing and single embryo transfer in the primary embryo transfer of favorable prognosis patients, suggesting the potential of this testing to increase the single embryo transfers and also to decrease the multiple gestations. There was a best trial which was being published, and the transfer of a single euploid embryo has become standard practice and is strongly recommended by the American Society for Reproductive Medicine. This recommendation is based on equivalent ongoing pregnancy rates with a significant decrease in the risk of multiple pregnancies and obstetric risks. So now briefly we'll talk about best trial. So the purpose of the best trial was to compare outcomes of single euploid embryo transfer with the transfer of two untested embryos. So why did the single embryo transfer come out as a strategy after the best trial? The study focused on women aged 42 or younger with at least two good quality blastocysts. Study design and criteria was PGTA group was with the single embryo transfer. All available blastocysts underwent biopsy with the quantitative PCR analysis. The single best quality euploid blastocyst was selected for transfer. Control group had double untested embryo transfer. Patients underwent transfer of the two best untested blastocysts based on only the morphology. So when we compared the ongoing pregnancy rates and the multiple gestations, we found that it was similar. The ongoing pregnancy was similar between the PGTA group and control groups. Multiples pregnancy rate was significantly higher in the double embryo transfer group. And in their study, they did not find any multiple pregnancies in the single embryo transfer groups. So the outcome of ongoing singleton pregnancies, the women who underwent single euploid transfer were nearly twice as likely as those undergoing the transfer of two untested embryos to have ongoing singleton pregnancy. Follow-up analysis of delivery outcomes demonstrated lower rates of preterm delivery, low birth weight, and neonatal ICU stay in the single euploid transfer group. So that is why now it is being recommended to do the single euploid embryo transfer. Now, the methods of pre-implantation genetic diagnostic and testing for aneuploidies has been summarized in this group with limitations and additional capabilities. What about PGTA for advanced age? There is increased embryo aneuploidy in advanced age. PGT helps reducing time to achieve pregnancy and live birth. For RPL, there is lack of evidence for increased live birth rate compared to expected management. It is very expensive, the PGTA. It is a very expensive method to reduce miscarriage without increasing the chance of attaining a live birth. And further study needs to be done to recommend PGTA for RPL as a standard treatment. For RIF, yes, studies have shown transfer of euploid embryo in women with RIF gives good clinical results in one transfer. So thank you for your patient hearing.
Thank you so much, Dr. Ankita, for that wonderful presentation. We have a few questions from the audience, so let's go through them one by one. So my first question to you is, what ethical considerations come into play when deciding whether to use PGTA for embryo selection?
So we have to make sure that there is ethical clearance. We have to counsel the patient that we may have a positive result and we may have a negative result. We have to counsel about the false positive and false negative rates of your institution. There will be a national and international standard, and there will be an institution standard. So we have to guide the patients about the false positive and the false negative rates. We also have to tell them that what are the implications of a positive result and what are the implications of a negative result, what are the implications of a mosaic result. So, after having counseled in detail, we have to have a thorough genetic counseling. We have to explain what is the implication of getting a positive result and knowing about it. And then we also have to guide them that when they do embark upon the pregnancy, careful monitoring at each stage has to be done. The ultrasound monitoring, the serum markers have to be done, and an invasive CVS or more preferably an amniocentesis has to be advised in order to be able to have a complete management plan in terms of ethical as well as a management point of view.
Thank you for answering that. My next question to you is there a cost benefit balance in using PGTA, especially in countries like India?
Yes, because mostly what we are doing here is PGT is being done for each embryo, whereas in other countries, it is being done per cycle. So whether you get 10 embryos or whether you get one embryo, you will be able to have the same cost in other countries. Whereas in our country right now, we are having, most of the centers are having a single embryo per embryo cost. Second important thing is when we are conducting the blastocyst stage biopsy, we have to make sure we have enough embryos, because if we do not have enough embryos, then we may not even go up to the blastocyst stage. Supposing a patient has only 2 or 3 embryos or 2 oocytes, then we're not making enough embryos and we're not having them go to blastocyst stage. We may even do a day 2 or day 3 transfer in such less amount of embryos. So we have to check for the cost benefit analysis, because testing for 1 or 2 oocytes and making embryos and then testing may not be cost effective. Whereas if we have more embryos, like 5, 6, 7 embryos, then it may be a more cost effective strategy. So we have to individualize and we have to counsel the patients accordingly, and we have to check their paying capacity in that manner.
Thank you so much for that answer. And thank you, Dr. Srivastava, for that enlightening session on pre-implantation genetic testing part 2. So your deep expertise and clarity have helped us better understand the complexities and practical implications of this evolving field in reproductive medicine. We also thank our participants for joining us today and engaging with us for this important discussion. We hope the session provided valuable learning that you can carry forward into your practice. We look forward to meeting you again in our upcoming sessions. Until then, stay safe and keep learning. Thank you so much.